Hello, and welcome to the updated recovery trial overview. The SARS-CoV-2 pandemic has caused over 10 million deaths as of late 2021, as well as massive global disruption. Vaccination is now limiting the impact of COVID in much of the world, but the virus will continue to circulate and cause many deaths for years to come. COVID treatments improved substantially since the start of the pandemic, because of the robust evaluation of potential therapies in randomised trials, like recovery. But mortality in hospitalised patients remains very high, and there's still an urgent need to improve treatment. The relaxation of public health measures will also lead to the resurgence of other respiratory viruses alongside SARS-CoV-2, most importantly influenza. Recovery has demonstrated the need for large collaborative trials to rapidly confirm or rule out worthwhile benefits of promising treatments. From the start, it involved nearly all NHS hospitals, and more recently has been expanding to other countries. Since March 2020, it's shown that in patients hospitalised with COVID, dexamethasone reduces the risk of death by around a fifth in those on oxygen, and even more in the sickest patients. The interleukin-6 inhibitor, tocilizumab, reduces the risk of death by a further seventh, and neutralising antibodies can reduce the risk of death even further by around a fifth in seronegative patients. Also, it's shown that many widely used treatments had no worthwhile effect: hydroxychloroquine, lopinavir, azithromycin, aspirin, colchicine, and convalescent plasma. New treatment arms will continue to be introduced, and from November 2021, this includes treatments for influenza pneumonia at sites in the UK, as well as COVID. With the introduction of flu, eligibility criteria for the trial have changed slightly. Patients must still be hospitalised with a viral pneumonia syndrome, for example with fever, cough, shortness of breath and compatible chest X-ray changes. However, now they also have to have confirmed SARS-CoV-2 and or influenza A or B infection. Confirmation can be with point-of-care tests, including lateral flow tests, as long as these are performed by a healthcare worker and documented in the medical record. The patient must also have no medical history that, in the opinion of the attending clinician, would put them at risk if they were to join the trial. The outcomes have remained the same, the primary outcome being all-cause mortality at 28 days after randomisation, and the main secondary outcomes are the duration of hospitalisation and the need for mechanical ventilation or death in those not ventilated at entry. This shows an example of the trial design before flu was included, in which patients with COVID could be included in one or more suitable treatment comparisons, that is, those that they're eligible for, are locally available, and not thought to be indicated or contraindicated by the clinical team. Patients can be entered into multiple comparisons simultaneously, and if they're ineligible for a particular arm, they can still be randomised to others. The design now that flu has been added is similar, in that patients can be randomised to any suitable comparisons, but now the type of viral infection determines eligibility. Here, the comparisons for patients with COVID are shown at the top, and those for patients with flu are shown at the bottom. And in the occasional patients that have co-infection, they would be eligible for both. After the clinical teams decided which arms the patients are eligible for, and the patients given consent, randomisation is done via a web interface. Baseline data is collected on the randomisation site, including the suitability of each treatment comparison. And patients are then allocated either to the additional treatment or to no additional treatment, with other care remaining the same. The allocations are independent, so a patient could end up being allocated all, none, or any combination of the suitable treatments. Further details about many trial procedures, including taking consent, randomisation and follow-up, are detailed in separate videos, as are the details of the current treatment comparisons. In summary, better treatments are needed to reduce mortality in patients hospitalised with COVID or influenza, and recovery is now evaluating promising treatments in both infections. The exact design of the trial will continue to change as new arms are added and old ones removed, and details of the current treatments can be found in the protocol and on the recovery trial website. Thanks for listening.